So I'm handing over the presentation to Dr. Trupti ma'am. She will be talking on anterior and posterior capsule related alarm bell surgical scenarios. Over to ma'am.
Good morning, everybody. Let's begin the first session of the last day of AIOC 2023. I'll be talking on my difficult anterior and posterior capsule related alarm bell surgical scenarios. This is a case of a fibrotic cataract. We see fibrotic cataracts very commonly in our region with very hard cataracts and calcified anterior capsule. A flax was planned in this case, and the patient was posted for toric IOL implantation. The fellow eye of this patient is pseudophakic, and we can see a optic capture. So maybe a PCR had occurred in the fellow eye. So we are keeping in mind that maybe in this eye there is a posterior polar cataract. So the plan of surgery is to post the patient for a flax capsulotomy and then do a phacoemulsification and be cautious of a PCR. We'll see what are the advantages of flax in such fibrotic cases. In patients who have a fibrotic cataract, flax has a distinct advantage because it is a closed chamber procedure. Flax capsulotomy in fibrotic cataracts makes it easier to cut over the capsule and cut the fibrotic bands. Because if we start a manual rhexis, initiation of the rhexis is very difficult and at times it tends to run to the periphery. Also, we need to give multiple cuts with scissors and the rhexis is not complete, so then it becomes very difficult to do a phacoemulsification. With the use of flax, the laser energy and the incision depth can also be increased in dense fibrosis. Also, we are going to use the technique of differential IOP. In differential IOP, we are going to use the different IOP settings, that is a physiological intraocular pressure between 18 to 22 millimeters of mercury, supraphysiological IOP between 23 to 34 millimeters of mercury, and the sub-high IOP between 35 to 45 millimeters of mercury. Here we can see that how by adjusting the IOP, we can adjust the safety profile in presence of the alarm bell situations. Now let us go to the video now. Here we can see that it is a fibrotic cataract, a calcified capsule, and the staining is done under using our own technique of 30 gauge needle under the air bubble, which will be discussed later on by Dr. Tushe. Here we can see that 80% of the flap is separated, but some of the flap it still remains, and when we try to separate it, we can see that there is a stretch on the zonules. At this point, a microvanous scissors is used and the flap is cut with a microvanous scissors, and remaining flap is then removed with the rhexis forceps. Now the cataract is very dense, so a short and deep trench is made, and using a sharp chopper with a single go, the two heminuclei are separated, they are chopped. We can see that there is good lateral separation on one side. Now the nucleus is rotated and the remaining lateral separation of the heminuclei is made. Everything has been going on fine till now, and at this moment here you can see that there is a underlying PCR which is noted. Now what to do at this point? There is a bulky nucleus which is present in the bag. The CCC is intact, but a central PCR is there. So now what to do? At this alarm bell sign, after this alarm bell sign, what we have decided is to change the IOP settings, to go to a lower IOP settings. Do not rotate the nucleus. Continue with the phacoemulsification in a very slow motion manner and use a IOL scaffold so that the nuclear fragments do not drop into the vitreous cavity. The plane of emulsification will be at a slightly higher level, supracapsular emulsification, and we can do a IOL capture later on. Toric IOL plus or minus, it has to be decided on table depending upon the capsular status. Now we continue with the surgery. See, you can see a underlying PCR there. One fragment or one heminucleus is held with a lower settings. The settings which were there at sub-high IOP have been lowered down. By doing cross-chopping, the nucleus is divided, the heminucleus is divided into two chops. And by gentle movements, in a very slow motion, this piece is emulsified. Throughout the surgery, you can see that the chamber has been maintained very stable, and in spite of underlying PCR, these fragments are not being pushed posteriorly into the vitreous, and no vitreous is coming anteriorly. Now the remaining heminucleus is there, which is gently rotated so that it comes in front of the phacoprobe, and getting an edge, it is held. Sorry. Let us see it once again. Here you can see the first fragment which was held properly, and then it was cross-chopping was done. The chamber has been stable throughout at this IOP settings. At a higher IOP settings, what happens is the chamber deepens and the nuclear fragments are pushed posteriorly. But this doesn't happen when we use a IOP of about 20 to 22 millimeters of mercury.
And the other thing is, you can see that due to the low IOP, there's a minimal pressure differences between the anterior and posterior segment. So you can see the nucleus is just floating in the anterior chamber. It is not pushing behind. So low IOP settings is a very useful tool. Yes, ma'am, you can continue.
Yeah. Now the remaining heminucleus is brought, and now it is divided gently by the cross chopping. At this point, it was decided that we will use the IOL scaffold technique so that these fragments are not pushed posteriorly. We have introduced viscoelastic substance through the side port so that the anterior chamber does not collapse, and now a multi-piece lens is introduced into the sulcus. The IOL scaffold technique is very good because it gives the surgeon the liberty to work at a deeper plane, and the corneal endothelium is protected at all times. Also, this IOL acts as a barrier. It acts as a posterior capsule so that the nuclear fragments are not dropped into the vitreous cavity. The IOL can either be dialed into the AC, and then the nucleus can be emulsified, or it can be put into the sulcus as we had put. Because an IOL is there, these fragments do not go posteriorly. We can see that the fragments were emulsified very easily. We have to keep in mind that the chamber has to be stable throughout the surgery. So before withdrawing the phacoprobe, viscoelastic has to be introduced. Now the IOL is dialed into the position in the sulcus, and we believe that whenever there is a posterior capsular rupture, a single piece IOL should not be implanted, and a multi-piece IOL should be implanted for the safety, long-term safety, so that there is no UGH syndrome. Now triamcinolone acetate is introduced into the chamber, and we see that there is no vitreous in the anterior chamber, and the surgery has been successfully completed. In the post-op period, it is very important to closely watch the patient for any inflammation or intraocular pressure rise, and a VR consultation is mandatory to see for any posteriorly dislocated fragments which may be otherwise missed. A good visual acuity of 20 by 20 with a cylinder of minus 1.5 diopters was achieved in this case. Now we go to a second alarm bell situation in which it was a very routine cataract, routine NS1 cataract, and the pupil size was moderate. It was around 6.5 mm of pupil. The biometry was normal, non-myopic eye, 18-19 diopters of IOL power. Let's see what happens in this case. The surgery is started. A postgraduate fellow is doing the surgery. A good CCC has been done and hydrodissection has been done. The wave of hydrodissection fluid is seen, which indicates that the nucleus is separated. Now trenching is begun. Now we can see that it is a very soft cataract, and yes, what happens here? You can see a round punch in the posterior capsule. The surgeon is oblivious to this, and the surgery is continued and trying to separate the nuclear hemispheres, and we can see at this point it is realized that something is wrong. We can see the exaggerated glow. So a PC rupture has occurred while trenching. Very importantly, viscoelastic is introduced to the side port, and then the phaco probe is withdrawn. What next? At this place, we have the entire nucleus, and at the first step itself, during trenching, there is a PCR. Either we can convert this case, or we can continue with phacoemulsification and keep the option of IOL scaffold in mind. What was our plan? The plan was, because the CCC is intact and it is a soft cataract, we will do the phacoemulsification at the low IOP settings. We will not rotate the nucleus, implant the IOL if possible, and change to IOL scaffold if required. Now, what is this low IOP? The physiological IOP is from 18 to 22 millimeters of mercury, and in this settings we use the AFR of around 23 in the sculpt mode and 26 in the quadrant mode, whereas in supraphysiological it is from 24 to 34 millimeters of mercury, and the AFR of 23 is used in the sculpt mode to 35 in the quadrant mode. By using these IOP settings, we achieve a very good stability of the anterior chamber, and the problems of deepening of the anterior chamber or hydration of the vitreous or loss of the fragments or the fragments moving posteriorly is not seen. The nucleus almost floats as it is where it was in the anterior chamber. Now the case is taken over by the senior surgeon. Because the trench is very deep, by a slight nudge, the two nuclear hemispheres have been separated, and gently with the stable anterior chamber, the heminucleus can be emulsified. See, the nucleus is just floating where it is. It is not going posteriorly in spite of having a PCR centrally. Now the remaining heminucleus is also just nudged. It is brought in front. No vigorous rotatory movements are made, otherwise these rotatory movements will cause the mechanical dislocation posteriorly. And this nuclear hemisphere is also emulsified very stably. The plane of emulsification is slightly anterior to what it might have been in the absence of PCR. Now again viscoelastic is introduced in the anterior chamber, and after that the probe is withdrawn. Now we have the cortical matter remaining. How to remove the cortical matter? Either we can use the irrigation aspiration, a coaxial irrigation aspiration, or we can use a bimanual. But before that, we tried to convert the PCR into a PCCC. It was not successful. The remaining cortical matter was aspirated using a coaxial IA probe. We can also use a bimanual IA in this case. Here what we do is, while using a coaxial, we slightly withdraw the sleeve of the irrigation so that the irrigation and the aspiration are at different levels. The cortical matter which was farthest from the rent was removed using a coaxial IA, whereas which was there in the area of the rent, that was removed using dry aspiration technique. Now the multipiece IOL is implanted in the sulcus, and we can do a optic capture. So these are the two alarm bell situations. See, this was the alarm bell sign in which the phaco punch occurred, and using the low IOP settings, we could complete the surgery successfully without enlarging the tear nor causing any dislocation of the nuclear fragments posteriorly. So we have to keep in mind about the settings which we are using, and definitely think of going to a lower settings to maintain a stable